Okay, with my apologies to Dr. Hahn and Bazanova, who can probably keep me straight or correct me if I make any mistakes here, we will finish up with what I think is really one of the most exciting approaches, and that is immunotherapy, particularly some of the newer monoclonal agents, and vaccines in lung cancer. And really, vaccines are part and parcel of immunotherapy approaches. So I've allotted 30 minutes. I'll try to do it faster, but this will be the last talk. We're having trouble advancing. Again, my disclosures haven't changed in the last 15 minutes. And I thank Dr. Hahn, who I stole liberally from her prior talk on this, although I've added and subtracted some parts. So immune surveillance in cancer is not a new concept. It was first proposed in the 50s. Problem is, lung cancer is not typically thought of as an immunogenic malignancy as we would typically associate with hematologic malignancies or even melanoma and renal cell. Retrospective analyses of tumor specimens from lung cancer patients have shown cellular immune responses against the tumor. They're often associated with a favorable prognosis. So higher tumor infiltration with CD4, CD8 T cells associated with better survival in early stage. On the other hand, in some cases, tumor-infiltrating T regulatory cells are associated with disease recurrence in some of these settings. When we go back to the 80s and 90s, we actually tried this. Interleukin and beta interferon were looked at either alone or in combination in lung cancer, extremely toxic with minimal efficacy. And I think at least for 15 or 20 years, we abandoned efforts in this regard. But this major excitement, both for vaccines and also the antigen-independent approaches using monoclonals in lung cancer. So this slide is straight from Dr. Hahn. The anti-tumor responses are mounted when tumor cell fragments are internalized by antigen-presenting cells, as shown here. The presenting cells internalize the tumor. They're fragments. They're processed and displayed in combination with class 1 and class 2 mixed histocompatibility complexes. And then these APCs interact with T cells and lead to activation and proliferation of tumor-specific helper and suppressor T cells with co-stimulatory interaction between a number of antigens, both on the tumor cell and the T cell and the dendritic cell. There are two basic approaches, active immunotherapy with vaccines that can be either antigen-specific, derived from the tumor cell, or dendritic cells or DNA, and then supportive antigen-independent approaches, and I would group lactoferrin under that as well as the checkpoint inhibitors. So first, vaccines. I'll go through most of these, but not all. A lot of data has emerged in the last year since Dr. Hahn's talk. Here's a small chart, again, courtesy Dr. Hahn, but actually courtesy Dr. Giaccone, looking at the various vaccines. And Lucanix or Belgian Pumacicel, again, unpronounceable, is distinguished from the other antigen-specific ones because it comes from the whole cell. And at least in early studies, it seemed to be associated with improved response rates. Here was the study design, stage 3 and 4, non-small cell with no evidence of progression after 1 to 6 cycles of first-line treatment. It was originally going to be quite large, 1,300 patients. I think they settled for about 500. Basically looking at maintenance therapy with this vaccine, given monthly for 18 months versus placebo. TGF-beta2 is expressed by tumors. It evades, that enable them to invade T cell activation. The whole tumor vaccine was prepared from irradiated non-small cell lines, modified to block TGF-beta secretion, therefore prevent tumor cells from escaping immune surveillance, so eliminate this blocker. Randomized phase 3 trial, as I pretty much designed the way I've shown you. They had to have stable disease or response after first-line therapy. Primary endpoint was survival, and they got 18 monthly injections. Unfortunately, it was negative. And this was just unveiled 2 months ago at the, I think it was the ECHO or ESMO meeting, one of the European meetings. So a press release came out just 6 weeks ago from Nova RX highlighting the fact that it was negative. I don't have the slides from the talk. but I have gleaned some of this. So 305 patients with advanced disease who enrolled less than 3 months after finishing their initial chemo may have had a benefit. So in this group, you see about a 7-month difference in the squamous cohort, 8.5 months. Those who had some radiation as part of their treatment, you see a 4-fold improvement in median survival. Again, this is post hoc analysis, hypothesis generating. This was not the main point of the study, but the hazard ratios here are promising. And whether this is going to be pursued further in a tighter maintenance setting, I think remains to be seen, but at least some hint of benefit, even if the overall study was negative. I don't have the overall median survival numbers. Dr. Hahn, do you know if they're out there someplace? MAGE-A3 is melanoma antigen family antigen. As you'd expect, it's associated with melanoma, about 3/4 of patients, but lung cancer, about 35 to 50%, as well as other solid tumors. Associated with poor prognosis, it's a member of a large family of genes. And the original trial, which was actually reported many years ago in early stage resected patients, was a randomized double-blind phase 2, 2-to-1 randomization of vaccine versus placebo. Started about 6 weeks after surgery, 5 vaccinations at 3-week intervals, followed by 8 vaccinations at 3-month intervals. Other anti-cancer adjuvant treatment was not allowed. And the primary endpoint here was time to recurrence. So 180 patients, well tolerated, just mild grade 1 or 2 toxicities, as is typical for vaccines. 29 grade 3 or 4 adverse events, but only 3 of these were potentially related to treatment, and only 2 patients actually withdrew from study. So if we look at disease-free interval, at least a trend favoring the vaccine approach compared to the placebo. Again, the study was not powered sufficiently for an advantage, but the p-value here is 0.107 with a hazard ratio of 0.73. If we look at overall survival, that hazard ratio is 0.66. Again, hypothesis generating, the confidence intervals to overlap unity. So this laid the groundwork for the Magritte trial. It's a phase 3. I think we mentioned it very briefly yesterday in Tracy's talk. So resected stage 1B through 3A, MAGE positive. They have to be screened for the expression of the antigen. 2 separate cohorts, those getting up to 4 cycles of platinum-based chemo, randomized to vaccine or placebo, and then a non-chemo group, the same randomization. This is the largest lung cancer study ever conducted. Began in October 2007. I think it completed accrual about 2 years ago, roughly. The goal was 2,270 patients from 400 centers in 33 countries. It actually over-accrued nearly 2,300 patients. Over 10,000 resected patients were screened for this trial. So it really is a monumental effort. And it's starting to get into breast cancer numbers. I mean, we're used to studies of 300, 400, 600. This was well over 2,000. And I think if it's not positive with that number, it's not going to be positive. So we don't know. The results are pending. It'll probably be, because it's resected patients who have an expectation of relatively long survival, it'll probably be some time before we see the final results. This year at ASCO, so this again is an update from last year's talk, we have the results of the BLP25 or MUC1 antigen study, the START trial. This is a liposome-based MUC1 vaccine. So just by way of review, MUC1 is a mucinous glycoprotein that's overexpressed and aberrantly glycosylated in non-small cell. And vaccination against it can result in a proliferative T-cell response to MUC1 antigen and the production of interferon gamma, correlating with the T helper type 1 response. This was the original randomized phase 2, looking at MUC1 versus control group, and specifically looking at the stage 3B cohort. And if you look here, you'll see a definite trend toward improved outcome. In the 2 years, that trend is significant, about a 30% improvement for MUC1 over the control arm, over the vaccine. That laid the groundwork for the START trial, which is a multi-center phase 3 randomized double-blind placebo-controlled effort comparing MUC1 to placebo. Again, 2-to-1 randomization. Patients were these are all locally advanced patients. So they've received chemoradiation. They're stratified by stage 3A or B. Response to primary chemoradiation, whether they're stable or actually had a response. The type of chemoradiation, which you'll see is quite critical, whether it was concomitant or sequential and then the region of the world with the appropriate DSMC review. So here's the study design, both really of the phase 2 and phase 3. It's weekly injections for 8 weeks, and then every 6 weeks indefinitely. I've had patients on this study, and they were getting treatment indefinitely, up to 3 and 4 years before the study was closed. The placebo group has the same schedule. Primary objective is survival. The usual secondary objectives, although they also looked at quality of life with the lung cancer symptom scale and time to both progression and symptomatic progression. Eligibility are fairly straightforward. Again, histologically or cytologically documented unresectable disease, good PS. They cannot be on steroids. And this is an issue when patients get chemoradiation for locally advanced disease. Many end up with pneumonitis. They're treated with systemic corticosteroids, and they, at that point, cannot go on the trial. So we lost a lot of people that might have otherwise gone on this effort. Again, they had to have at least had stable disease after chemoradiation, a minimum of 2 cycles of platinum-based chemo, and a minimum radiation dose of 50 gray. They had to have completed the chemoradiation at least 4 weeks, but no more than 3 months prior to randomization. I don't know why they allowed prophylactic cranial radiation. It's not standard in non-small cell, but some people have used it. And fairly liberal parameters for hematology. So platelets of 100,000, white cell count of 2,500, hemoglobin of 9. Again, presuming that many of these patients are still recovering from their chemoradiation. The plan was 1,300 patients, again, 2 to 1, looking for a hazard ratio of 0.77 with a one-sided alpha of 0.025. They don't care if the placebo does better than the vaccine. They want to show that the vaccine does better than the placebo. And pretty high power at 90%. So this trial also over-accrued 1,470 patients, finished accrual about 2.5 years ago. Here are the demographics, fairly typical for a locally advanced population. 2/3 were male. Most were former or current smokers. About 1/4 were current smokers. Never smokers were only 6%. And the plurality had squamous cell, a slightly higher proportion on the MUC1 arm. Most of these folks had responded to chemoradiation, about 2/3. And the majority, almost 2/3, got concurrent chemoradiation, which is important. About 60% had stage 3B disease, and you see a pretty even distribution across the world. For whatever reason, Australia was grouped with North America for the analysis, even though we are a good 8,000 miles from each other. Trial was negative overall. So the p-values here are 0.123. The hazard ratio is 0.88. You see about a 3-month difference in median survival, maybe a trend, but not statistically significant. Time to progression was borderline significant, p-value 0.053, again about a 2-month advantage. Time to symptomatic progression was in fact statistically significant, 3-month advantage with a p-value of 0.023. But if you look at the large, actually 2/3 of patients who got concurrent chemoradiation, you do in fact in this analysis see a survival advantage, about a 10-month difference. P-value is 0.016 with a hazard ratio of 0.78. These are huge numbers. This is 850 patients. That cohort alone is larger than any trial I know of that's ever been done in locally advanced non-small cell. On the other hand, if you look at the sequential cohort, the placebo group, for whatever reason, seems to be doing better. About a 4 or 5 month difference, though it's not significant. Here are the hazard ratio, the forest plots for each of the concurrent and sequential cohorts. And in the concurrent group, regardless of a demographic variable, you see a putative advantage, again, regardless of gender, performance status, LDH, smoking status, or histology. So here's the summary in a tabular format. Flu-like symptoms that are very mild, some injection reaction, otherwise very well tolerated. And the paradoxical observation that in the placebo group, the sequential cohort is actually doing better than the concurrent cohort. We have multiple studies in locally advanced non-small cell that have compared concurrent chemoradiation to sequential chemoradiation. Concurrent always does better. But in this study, for whatever reason, again, they weren't compared directly, the sequential group did better with placebo. So why did the concurrent cohort seem to benefit? Well, radiation may be immunogenic, enhancing the activity of MUC1. Inflammation is common after chemoradiation, which can potentially lead to pro-inflammatory cytokines and upregulation of the MUC1 gene. Concurrent therapy is probably a better platform Best results in locally advanced disease have been seen with that platform, at least historically. It's superior to sequential therapy. Concurrent therapy may also have better selection. Think about the patients that go on this trial. They're more likely to have undergone PET and mediastinoscopy, so fewer occult stage 4 patients in this group, better outcome with taxanes, which are often given concurrently with radiation, and less time to initiate the MUC1. They're not going through both chemo and then radiation sequentially. They're getting the MUC1 vaccine sooner, so a smaller chance to develop metastasis. Regardless, we need a confirmatory trial, and that is actually planned. These results, I think, are too important to discard, but unfortunately insufficient to justify approval. We'll finish up with the other immunotherapy approaches that are antigen independent. Again, I've stolen this slide from Dr. Hahn. Thank you. Human lactoferrin is a modulatory protein expressed in immune cells and on all body surfaces. Exposed to the external environment, it plays a central role in establishing the immune system, including GALT, or gut-associated lymphoid tissue in infants. And TLF is a recombinant human lactoferrin, 80 kilodaltons, that's produced in Aspergillus niger. Promising results in phase 2. This was a trial, I think, mostly done in South Asia, comparing lactoferrin to placebo in pretreated patients. You see about a 3.5-month survival advantage. Unfortunately, the phase 3 study in refractory disease failed to meet the primary endpoint of either overall survival PFS. And as I recall, the curves were pretty much overlapping. There was no obvious benefit. So further development, at least of lactoferrin, is not contemplated. And then, of course, we have the checkpoint inhibitors. So Ipilimumab, which, as you all know, is approved in melanoma based on trials that have shown the survival benefit compared to standard treatment as well as observation, is a fully human monoclonal that targets CTLA-4. It augments T-cell activation proliferation, leading to tumor cell infiltration. And early studies has actually demonstrated activity in a broad range of tumors. It's also fairly toxic, not just pruritus, rash, and diarrhea, but autoimmune reactions, including adrenal, pituitary, and thyroid problems. So this drug has been grafted onto chemo. This is a randomized phase 2, and I actually quite like the study design here. Takes Pac-Carbo, gives it either concurrently or in a phased approach concurrently during the 3rd cycle and beyond versus a control group. And then Ipi is continued at regular intervals after the completion of chemoradiation. I believe at 3-month intervals in that group. And if we look at activity based on histology, the combined groups seem to do better, and particularly the squamous cell population. Now, again, these are small numbers, but a putative PFS and overall survival advantage for those getting the phased Ipi approach, so 2 cycles of chemo followed by combined Ipi and chemo. And here are the actual curves in the squamous cell cohort, so a 3-month difference in median survival and a hazard ratio of here of 0.48 compared to the control. Less badly tolerated than you might have expected. And that may have to do with some of the steroids that are frequently used as part of prophylaxis with taxane. So relatively low rates of grade 4 toxicity summarized here. So overall, grade 3 and 4 AEs are pretty much equivalent across the board. Some immune-mediated hypophysitis, GI toxicities, and hyperthyroidism. There were no grade 4 dermatologic or GI immune-mediated AEs. Hypopituitarism and adrenal insufficiency were not seen. Some low-level hypothyroidism, which I think was very easily treated. Drug-related discontinuation was relatively rare. There were 2 treatment-related deaths, one in the control arm, neutropenic sepsis, and one in the concurrent group due to toxic shock. So this has laid the groundwork, the relative safety and the squamous cell findings for what I call an opportunistic study, looking specifically at squamous cell carcinoma. So Pac-Carbo, standard either alone, and note that they lowered the Pac dose here to 175 per meter squared, either alone or combined with Ipi given during the 3rd and subsequent cycles, and then continued as maintenance therapy. Overall survival is the primary endpoint. The study is ongoing. It's accruing. It was sluggish initially. I've been told that it's starting to pick up. It was initiated at least 2 years ago, and I think they're hope is to finish accrual at least in about a year. So stay tuned, a very important trial. And then, of course, we'll finish up with the PD-1 and PD-L1. Julie Bramer presented these data last year. They've been updated both at this year's ASCO and at World Lung. And some of the preliminary data was published in the New England Journal. So again, as we pointed out, PD-1 is expressed on the T lymphocytes and PD-L1 at the level of the tumor. And basically, you're unblocking the immune receptors, enabling T cells to do their work, so to speak. So this is a fully human, anti-human PD-1 blocking agent. Blocks both PD-L1 and PD-L2. Unlike cetuximab and some of the other monoclonal antibodies, it has no known ADCC, manageable toxicity profile, and primary evidence of clinical activity in refractory tumors. The study design was a dose escalation of 1 to 3 to 10 mg/kg every other week. Disease progression off study, unacceptable toxicity on study, but discontinued treatment. And those with stable disease or better were essentially continued on this approach for up to 96 weeks, so nearly 2 years. 122 patients in the non-small cell cohort. The majority had received 3 or more cycles of chemotherapy, and the vast majority had platinum-based treatment. You see about a third had TKIs. All had good performance status, and the majority were non-squamous. These are the toxicities overall, and definitely a bit more toxicity than you typically see. Grade 3 and 4 is relatively rare, but don't discount the effects of grade 1 and 2 fatigue, some rash, diarrhea, pruritus, some anemia, and fevers. Responses were seen across the board. 3 mg/kg seems to be the threshold dose. 32% response rate initially, 18% for the 10 mg/kg group. And this was updated this year at both ASCO and ISLAC. If we look at the 3 mg/kg group, it's 27%, and for the 10 mg/kg group, 17%. These are heavily pretreated, essentially refractory patients that are getting a single-agent immunologic therapy. We have not seen this before. Granted, the response rates are relatively meager, but typically chemo in this setting is 2% or 3%. If we look at the breakdown by histology, initially the squamous cell cohort seemed to be doing better than non-squamous. I think that's more or less equaled out. We have 9 of 35 with squamous responding, and the non-squamous group 10 of 55. So similar response rates, maybe a little bit better for the squamous cell group. And these are fairly durable. Disease-free, progressive-free survival at 6 months, 44 and 51% in the squamous cohort at 3 and 10 mg/kg. Last year, I was introduced to these curves. I had never seen them before. These are called spider plots. We have waterfall plots. Now we have spider plots. So this really plots out the duration of benefit. So anything below the x-axis is a response, and you're actually tracking the duration of the response. Anything above the x-axis is disease progression. And needless to say, the spider's legs are foreshortened here because they're progressing and they're not continuing on treatment. So at 3 mg/kg, you see benefit. At 10 mg/kg, you also see benefit. And that seems to, 3 mg/kg seems to be the threshold dose. We've also seen this phenomena of pseudo-progression. This is a EGFR mutant patient with T790 acquired resistance, treated initially with gemcarbo, then erlotinib, and a LBH589 in a trial for T790 mutation, then subsequently pemetrexed. So lots of prior treatment, and then went on to nivolumab. Most studies, you take a patient off if they had a scan like this, but lo and behold, at 4 months, you're seeing a putative benefit that you would not typically see with standard systemic therapy. And this is another example. I don't know if this is your patient, Dr. Bazanova, but 58-year-old ex-smoker with squamous cell, 4 prior therapies for stage 4 disease, lots of flank pain. You see a big lung mass that's regressed, a pericardiac mass that's regressed, an adrenal mass that's regressed, and then a liver met that's regressed. And this response is ongoing at 2 years. Now, obviously, we trot out the best scans, but this is not happening in rare individuals. We're seeing this in at least 15 to 20% of those enrolled. There seems to be a putative correlation of PD-L1 expression and response. This is some of the early data. I think there are a lot more cases now Those who lack PD-L1 expression also do not seem to have any response to treatment. So clearly safe overall, durable clinical benefit in both squamous, which I consider to be the orphan population, and non-squamous. Early findings suggest that this is a reasonable target, and we have preliminary data correlating PD-L1 expression in pretreatment tumor biopsies and with response. BMS has developed a cottage industry of trials investigating this agent. So this is an ongoing effort comparing to docetaxel second line. It's a phase 3 registration trial with survival as the primary endpoint, looking for 574 patients in the non-squamous cohort, and then a smaller squamous-only cohort of 264 docetaxel versus Nivolumab. We have patients who have received at least 2 prior systemic treatment, a 100-patient trial of single-agent Nivolumab, and then sort of chemo du jour, grafting Nivolumab onto gem and cisplatin in the squamous cohort, PEM-CIS in the non-squamous, and then histology independent with Pac-Carbo. So randomized, not really a randomized phase 2, but separate cohort trial. Those are arms A, B, and C. Then we have D, E, and F, grafting it onto erlotinib and EGFR mutants, Bev maintenance in the non-squamous group, and then single agent any histology in the F arm. And then combinations with Ipilimumab, which actually have shown quite a bit of promise. I don't have any of the cool films, but certainly in melanoma we've seen activity. So various doses of both agents together in advanced disease, looking at least initially safety and tolerability, but clearly response. And then also maintenance therapy. This is really switch maintenance in the squamous population after 4 cycles of platinum-based treatment, and then non-squamous, either alone or combined with bevacizumab, and then in patients with asymptomatic brain mets. So those are arms K, L, and M. If you tally it all up, it's a double octopus trial. So lots of studies, lots of opportunity to get people on studies, basically looking at this agent in essentially every clinical situation you can envision. This is not the only drug. There are a number of companies that are looking at their own agents. Merck, MedImmune, Genentech all have either PD-1 or PD-L1 antibodies. I'm going to just briefly mention the Genentech compound. This was presented by David Spiegel at the ASCO meeting and then updated at World Lung. So PD-1 antibodies additionally block PD-2, which may result in increased autoimmunity. PD-L1 antibodies block B7-1, which may promote more immunogenic cytotoxic T-cell priming, and whereas PD-1 antibodies might not. So possible advantage, we don't know. So again, activated T-cells express high levels of both PD-L1 and PD-1, and PD-L1 can dampen the anti-tumor immune response, so we're trying to reverse that. PD-L1 expression, I've been told, is about 50%, maybe 45% in adeno, 50% in squamous. These numbers are still emerging, but probably about half the patients we test. And most, with the exception of the BMS trials, all of the other agents are requiring PD-L1 testing and requiring the patients to be PD-L1 positive. So these are the data I gleaned from the World Lung Meeting, looking at the Genentech compound. 385 patients total with metastatic disease. Lung was just one cohort. This is given every 3 weeks for up to 16 cycles, so basically a year with retreatment at disease progression. Primary endpoint, again, is safety and tolerability, but of course we're looking for responses. 85 folks with non-small cell, median age was 60. Fairly standard demographics here. You see about 3/4 were non-squamous. Over half had received 3 or more prior regimens, and about 20% were never smokers. So essentially a typical heavily pretreated refractory lung cancer population. Majority of AEs were grade 1 or 2 and did not require intervention. No dose-limiting toxicities. Unlike the other compounds, at least the PD-L1 so far, no grade 3 or 5, grade 3, 4, or 5 pneumonitis. 1 treatment-related death that may or may not have had to do with the primary tumor, and immune-related grade 3 to 4 AEs in just 1 patient so far with large cell neuroendocrine. That was diabetes. So if you look at the IHC expression for PD-L1, there seems to be a correlation with response. The 2s and 3s have about a 46% response rate. Many of these are quite durable. This is up to a year of treatment, some of which are ongoing even in the absence of continuing the drug. 5 to 10% seem to have pseudoprogression. At 6 months, 45% are progression-free. There seems to be a dose threshold, as we've seen with some of the other drugs. And PD-L1 expression doesn't seem to have any exclusivity with other markers. So you can see this with MET. You can see this in KRAS or EGFR mutants, totally independent. Perhaps a slightly higher response rate in those with KRAS or EGFR wild type. So there are 4 separate trials, all named after trees: fir, birch, poplar, and oak. I don't know where they come up with these titles, but certainly that's unique. The first is in phase 2, PD-L1 positive advanced disease, single agent that's ongoing with response rate. This includes first and second line and beyond, as well as those with CNS mets. The second is a phase 2, much larger trial that's just starting, 300 patients, including first, second, and third line. The Poplar trial is a comparative effort, 180 patients comparing docetaxel second line to PD-L1. And then the Oak trial, I guess they want to base their registration on a sturdy oak, is an 850-patient trial, phase 3, comparing docetaxel to the Genentech compound with the primary endpoint of overall survival. So again, stay tuned. We are having a tsunami of trials focusing on these agents, and they all look quite promising. So I will conclude here. Treatment with this agent was well tolerated. No pneumonitis-related deaths. Rapid and durable responses have been observed in about 20% of patients. PD-L1 tumor status seems to correlate with response, and multiple single-arm and comparative trials are ongoing. And finally, vaccines, I would argue, have shown promising activity in phase 2 studies. Phase 3 studies are either underway or have been completed. And certainly the MUC1 trial has shown promise. Lactoferrin, I think, is probably off the charts at this point. And the checkpoint inhibitors, which are really the major excitement in the last 18 months, are active with often durable responses in heavily pretreated patients. These folks have exhausted standard treatment. Unique side effects that are associated with the immune system may be more effective in squamous cell, although that seems to be less obvious over time. PD-L1 seems to be the therapeutic biomarker. There may be others, and then randomized trials, of course, are ongoing. So I will end with great promise, and I think this is really something that we will see evolving rapidly over the next year or two, and hopefully one or more, maybe many of these compounds will prove positive and will ultimately hit the market and improve outcome, because remember, the vast majority of our patients do not have actionable molecular abnormalities, and these agents, 50% or so, are PD-L1 positive. So thank you for your attention. I actually finished 3 minutes early. Thanks.